Welcome to AETCM, the Emergency Medicine Channel.
Yes.
It's a 30-year-old male presented to ER with complaints of agitated behavior and irrelevant talk for the past 2 days. Initial 10-second assessment, airway was patent with no gargling, stridor or pooling of secretion. Breathing, respiratory rate of 28 per minute with a saturation of 98. Bilateral air entry present. 28. It's agitated, so it was tachypneic or so. Saturation full 98%. Circulation, heart rate of 94 per minute with a BP of 130/80 with all peripheral pulses palpable. Disability wise, GCS is 14/15 with no obeying commands. GRBS of 180 ml per DL. Exposure temperature is appropriate. Since patient was aggressive with tendency to attack others, hence physical restraint was applied. Sedation was given with injection lorazepam 1 mg. IM was given.
1 mg IM.
1 mg IM. Then sample history, 30-year-old male, non-case of schizophrenia.
And he got sedated after?
He was mildly sedated, sir. But still that talk was persisting. 30-year-old male, non-case of schizophrenia, presented to ER with aggressive behavior and irrelevant talk for the past 2 days. Schizophrenia. Patient was isolating himself for the past 1 week with a bystander, that's father, finding him talking to himself and arguing with the wall multiple times.
With the?
Wall.
Okay.
Then these symptoms gradually progresses and patient become violent since yesterday, saying someone is trying to kill him if he does not kill his neighbor and try to assault his neighbor. So they came here for further evaluation. There is history of non-compliance to medication for the past 2 weeks. A similar episode in the past present and was admitted in our psychiatric department for the same. Then patient also complaining of auditory hallucination, like someone is talking to him repeatedly. He was mumbling about that also.
But he got sedated, right?
Before sedation. Bystander told the history of this recurrent assault, like recurrent feeling like someone is about to kill him if you don't kill his neighbor.
Okay. So basically you weren't able to take history from the patient. So he already got sedated.
Sir.
1 mg itself he got sedated.
No sir. My proper history can't be taken because patient was not at all in a state to take a proper history. 1 mg, 4 mg midas we given,
4 mg.
4 mg midas IM we given. No history of fever, chills, seizure, syncope, any substance abuse. No history of chest pain, neck pain, vomiting, any focal neurological deficit was there. So on examination.
No, basically, this thing in the case of known case of schizophrenia came with agitated behavior and hallucinations. So you should you ask the bystander about the ODPARA. Onset, duration, intensity, progression, previous episodes, aggravating relieving factor, associated symptoms, details you will have to take, and then you have to move on to the psychiatric history.
ODPARA, that like patient was started to isolate himself for the so onset was 1 week back.
This particular case is a schizophrenic patient, violent schizophrenic patient, and this particular case will be how to sedate such a violent patient. So the topic will be acute behavioral disturbance and management of acute behavioral disturbance. Another scenario will be where this patient is already schizophrenic and he is cooperative and he will tell the history to you also. He is not agitated, he is not combative. So that's another history. In such a case, you can take the detailed ODPARA and then the psychiatric history you can take on the 4 domains like cognition, psychosis, self-harm. These are the 4 domains in which you will have to take the psychiatric history and then do a mental state examination. That appearance, behavior, thought, everything you can take in detail.
So
this particular case is acute behavioral disturbance. And apart from taking this thing, you'll have to take past history, personal history, specifically for psychiatric patients. Take a social history, detailed social history. What his job is, how is his behavior with other people. Is there any similar problems in the past, and is there any involvement with the police? These kind of things. Is he a drug addict? Is he dependent on any drugs or anything of that sort? You can ask. Is he currently on any medication? Is it a side effect of those medications? I don't know. All those things will. What was he was on some drugs, right?
Daily medication.
Yeah.
Like he was on TCS, tries antidepressants and antipsychotics, both were there.
Antipsychotics, the thing was there. Okay. So basically, the stations which you can get in OSCE is either case of acute behavioral disturbance. You won't get as a scenario in a OSCE station. You get either depression or psychosis or mania, bipolar, schizophrenia, or substance abuse or alcohol. These are the stations which you are likely to get in the OSCE. This you won't get. Agitated and combative patient you will never get in OSCE, because the domain testing is different. You are basically sedating him.
So this is a case of acute behavioral disorder. As you say, sir, we will deal with two scenarios. In first scenario, patient will be agitated, like the patient we have right now, where first thing we have to do is to sedate the patient. So we use a assessment tool, like sedation assessment tool that is SAT assessment, where we will score the patient as 3, 2, 1, 0, -1, -2, -3 in view of responsiveness and speech. So score 3 is the patient is combative, violent, out of control, and the speech is continuous, loud outburst. Score 2 is very anxious and agitated with loud outburst. Score 1 is anxious, restless, but normal, talkative patient. 0 is awake, calm and cooperative, speaks normally. -1 is sleeps but aroused if name is called, slurring or prominent slowing of speech is there. Then -2 is response to physical stimulus. Few recognizable words is only speech he is telling. -3 is no response to stimulus and no speech. So this using the STAT score, we will tranquilize the patient by rapid tranquilization protocol in acute behavioral disorder.
Basically, the SAT score 2 or 3 requires tranquilization, because less than 0 and all patient is already sedated. That drowsy state. No need for sedation as such. 2 and 3 is completely agitated, combative.
So this rapid tranquilization protocol for acute behavioral disorder, where the patient will be assessed by a senior doctor regarding the capacity, patient's lack of capacity, if patient represent a significant danger to himself or other, if patient required emergency treatment or investigation, if patient is severely agitated, and doctor also consider whether patient may be potentially life-threatening ABD. So then we will take de-escalation measure undertaken if possible. De-escalation techniques or exclusion will give, and will give oral medication lorazepam 1 to 2 mg.
Verbal de-escalation.
Verbal de-escalation.
Verbal de-escalation, then
followed by parental de-escalation.
Environmental de-escalation.
Environmental de-escalation, then rapid tranquilization. Like basically we will first verbally
step is always verbal
de-escalation.
But try to calm down the patient rather than before giving medicine. Try to calm down. And you try to, the environment itself should be really safe.
We'll respect the patient's personal space. Doctor should not be very much provocative. We should establish a verbal contact. We have to introduce the patient, introduce ourselves to the patient, and be concise and repeated whatever he is saying to make it concise conversation. Identify the wants and feelings of the patient and clarify statements. We have to give a set clear limitations and offer choices and optimism, and debrief the patient and staff after the communication. This is the verbal de-escalation. Next is we will do an environmental de-escalation, where we will keep the patient in a safe, calm environment with an escape route for us. We have to scene safety basically. For us, door should be open on both sides. A quiet room with no stimulus should be the one we have to take care.
And the glass should be there, no? The other people should be
able to observe us from
what's going on inside the. If they are trying to attack us or.
Scene safety for our own safety.
Yes.
Then only we will introduce a rapid tranquilization or sedation, which is mostly parental, in which a patient should lack the capacity to refuse treatment, incompliant and causing danger to himself and to the others. Mostly it is oral or parenteral we can give. Orally medication is lorazepam 1 to 2 mg, maximum of 4 mg per day we can give. Then
Loraz.
If in the case of parenteral, we will go for ketamine 4 mg per kg.
This is 2 mg and 4 mg.
Ketamine is 4 mg per kg.
Loraz
oral 1 to 2 mg. Orally we can give. Then ketamine 4 mg per kg IM or droperidol 5 to 10 mg IM we can use.
That's the difference. Ketamine is 4 mg per kg. Whereas droperidol is
5 to 10 mg.
It's not per kg.
5 to 10 mg IM. If these two medication is not available, we can go for midazolam 5 to 10 mg IM or lorazepam 4 mg IM or haloperidol 5 mg IM or haloperidol plus lorazepam. Haloperidol 5 mg plus lorazepam 2 mg combination can also be used if domperidol or ketamine is not available.
That usually what we give is haloperidol with Phenergan combination. Serenase Phenergan. Usually we give Serenase 5 mg, Phenergan 12.5 mg. But as per these guidelines they have mentioned, Serenase 5 plus lorazepam 2 mg. So Phenergan they haven't mentioned.
So once sedation is taking effect, we will establish and secure intravenous space, monitor in a high dependency unit, and maintain sedation with IV bolus medication until definitive management or plan is arranged. If there is any electrolyte imbalance, glucose,
infusion.
Multiple bolus doses we can give. Infusion also, but infusion can we can't assess the mental status if patient is improving or not. So we prefer bolus doses. Correct electrolyte, glucose or any acid-based disorders or correct hypothermia.
Basically, if a patient came, a combative patient, as the patient is a threat to other people, you immediately do a SATS scoring system. If the SATS scoring is 2 or 3, then you immediately do a verbal de-escalation, mental de-escalation, give drugs such as ketamine or droperidol
or midazolam,
or orally if the patient is okay, we can give a lorazepam. And if this is not there, you can give lorazepam, right?
Yes.
And bolus is also you can give. Or Serenase plus haloperidol with lorazepam you can give. And
maintenance can be done by diazepam or lorazepam, sir. Diazepam is 0.3 mg per kg IV or lorazepam 0.03 mg per kg and tighter the dose.
Then you will have to find out whether it is really because of psychiatric
problem, any other underlying
abuse, or is it because of some other organic causes which is.
The other DDs for this acute behavioral disorder include substance intoxication, previous mental disorder, substance withdrawal, serotonin syndrome, hypoxia, hypoglycemia, electrolyte disturbance, sepsis, head injury, anticholinergic syndrome, neuroleptic malignant syndrome, thyroid storm, heat stroke, seizures, everything we have to rule out. We have to rule out other organic causes for encephalitis, meningitis, other causes, and take a proper history, and predisposing history should be done after the patient is sedated from the bystander. Then this is a agitated patient. So in case of normal patient, if patient is not at all agitated, normal schizophrenic
patient, psychiatric consultation.
Psychiatric
if everything is ruled out, a psychiatric consultation.
This after ABD, everything organic causes is ruled out, we can give a psychiatric consultation for further management. So in case of a normal patient who comes to us with saying someone is talking to him, but not agitated patient, already schizophrenia or any other psychiatric illness patient. So we will take a detailed history from the patient itself, including a mental state examination. In mental state examination, main components include appearance. Appearance factors to consider are dress unkempt, self-harm, physical disorder, inappropriate dress, previous deliberate self-harm. Behavior, that include cooperation, aggression, disinhibition, distress, preoccupation. Speech, the amount, spontaneity, volume, flow, everything should be should be observed. Mood and affect, subjective versus objective, posture and facial expression, suicidal ideations, plans or intent, thought form, tangentiality, circumstantiality, association, neologism, flight of speech. Then speech content, that is very obsession, delusions, abnormal perception, hallucinations or sensory modalities. In case of cognition oriented as attention, memory, intelligence, insight, patient's understanding and expectation of his condition. These have to be
basically appearance,
behavior,
all this thing, dressing and everything, behavior,
Speech, mood
the
and-
rate of the speech, the tone, everything has to be. And then appearance, behavior, speech, mood. Okay, then high mood or low mood or whatever it is. Then
affect, cognition, thought form, thought content, suicidal ideation, perception, insight.
So in schizophrenic patient, what are the things? What do you expect?
Thought formation, thought content. Mostly it's a thought disorder. So patient
problems
may
in
have patient may have withdrawal, insertion of thought, withdrawal of thought. Someone thought blocking,
Somebody is
thought
trying to
insertion.
block your thoughts, or somebody is trying to put their thoughts into your mind, or somebody is trying to steal your thoughts from your mind, or the patient will feel as though your thought is they're
controlled by someone else.
They somehow they're like what you're thinking, they are able to understand, or they're trying to control you. That's passivity. Somebody is controlling you. That is what. Then hallucinations, like delusions. Hallucinations, like
Auditory
in the form of auditory
hallucination,
hallucinations. People are speaking about you, or you are hearing some unwanted noises which other people are not able to hear, or something is
Tactile hallucination.
hallucinations you may get, or even delusions. So these are the classic features of schizophrenia.
So, like taking a psychiatric history should be presented with psychiatric condition, disturbed patient, or those with altered mental state. The following components we have to take is identifier like name, age, occupation, location, then presenting complaint, a brief description, ideally in the patient's own words, of why they are attending to the department. History of presenting complaint, time of onset, as you say, sir, OD-para, onset duration, like incident association,
The intensity
progression,
aggravating factor.
Past psychiatric illness should be mentioned, past surgical history should be mentioned, then drug history, any current drug dosage change, any non-compliance to drug, route or frequency, non-allergies, reaction, intolerance to drug, social history about the employment status, living arrangement, smoking, drinking, alcohol history, normal functioning capacity, XML mobility and independence, family history or any family members having similar psychiatric illness, or personal history including childhood development, family tree, parental issues, schooling, employment, relationship, children and social circumstances, financial issue and forensic issue should be explained. Then after ruling out organic cause, if signs and symptoms of psychiatric condition suggestive of organic cause include history of substance abuse, over 35 years of age of first presentation, fluctuating behavior, prominent visual hallucination, lethargy, abnormal vital signs of poor cognitive function. It's more pointing towards organic.
Age more than
than
35, visual hallucinations. It's unlikely to be psychiatric. More of a drug abuse, substance abuse. problem.
So, organic causes that can lead to disturbed behavior include traumatic causes like head injury, acute or long term, infective causes like HIV, encephalitis, syphilis, malaria, meningitis, cerebral toxoplasmosis, neurological causes like
Rabies and hepatitis.
rabies, Parkinson's, CVA, epilepsy, Huntington's chorea, cardiac condition like a mitral valve disease that can cause anxiety, autoimmune like SLE, neoplasms in frontal lobe, temporal lobe, paraneoplastic problems, example hypercalcemia, bones and blood like hemolytic anemia, endocrine like adrenocortical disease, thyroid disease, phlebochromocytoma, degenerative diseases include dementia, visual hallucination, partial sight, drugs like alcohol, illicit drugs and steroids, idiopathic causes like genetic disorders like Huntington's disease, storage disorders like Wilson's disease, obstructive gynecology like preeclampsia, postpartum, everything can cause behavior disorders. In investigation and management, basic blood works.
Post-traumatic stress disorder.
PTSD.
If it is a female, you'll have to definitely ask whether there is any recent childbirth, things like that. When was it? Any issues pertaining to that childbirth?
Basic investigation include blood glucose level, urinary, thyroid function, full blood test, liver function, CT brain can be done if the patient is first time presenting. Once the organic causes are ruled out and psychiatric diagnosis is determined, more suitable admission should be there in patients who are presented with first episode of psychosis, suicidal or homicidal ideation, great deliberation from illness, gross debilation from illness, lack of capacity to consent or compliance with treatment, and inadequate psychosocial support in the community. Then if the patient is having the tendency for self-harm, we have to take certain key factors of recommendation involved, including having no ligature points, eliminating physical obstructions that may impede observation of high-risk patient, increase observation during evening and nights, and conduct a risk assessment prior to discharge. Then we have to involve the psychiatric department for further evaluation.
Clear?